we go back.
ACTH. Sir, Visolone is being given, so ACTH, no, but already pituitary has been removed, na sir?
Pituitary removed, radiation given. And this is a very, very common mistake which happens at interpretation level. What you are checking in the lab is serum cortisol. And when we give prednisolone, prednisolone is not reflected in the cortisol assay. If you give probably hydrocortisone, you might be able to pick it up. If you give dexamethasone or prednisolone, your endogenous production is going to be even less than what it was before. So if you give prednisolone and try and assess cortisol value, it is going to get lower and lower, and the dose was getting higher and higher and higher, which is, if you give 15, it will go even lower. If you give 20, it will go even lower. So idea was, and this patient became clearly Cushingoid because of iatrogenic steroid replacement. So the point is that while on prednisolone therapy, we cannot assess cortisol levels and we cannot interpret them. No way. The monitoring will have to be clinical, sometimes based on other parameters, but we cannot use the cortisol assay to measure adequacy of prednisolone replacement, quite in contrary to thyroid, where we can easily assess do a TSH to find out the adequacy of thyroxine replacement. So this gamut doesn't hold true for adrenals. Alright, this is a 34-year-old male. He has been having recent weight loss, fatigue, palpitations, but had kind of ignored them. He attended a party, had some alcohol, had heavy food, went to his room, slept. He woke up at about 3 AM to pass urine, and then he found that he could not really get up. He was very weak in the legs and he could not move his arms. He called out. He was taken to a hospital where he was clearly noted to have tachycardia and a goiter. He was suspected to have thyrotoxicosis, which came back positive. Of course, he had clearly high T3 and T4 levels. But at the time of admission, he had a clear forelimb weakness and neck weakness. His deep tendon reflexes were depressed. So what would be the test that you would do at this point of time? Anything comes to your mind? This is actually the test that you would do would be potassium, and this person had a thyrotoxicosis associated hypokalemia. And it's not a very common entity, but we do see it at least 4 or 5 times a year. It's very typically common in Asian males. And this potassium abnormality is basically because of a lot of driving in of the potassium from the so it basically is driven intracellularly, and that is because of high activity of sodium potassium ATPase, which is driven actually by high thyroid levels. So the treatment for this is actually to control the thyrotoxicosis. This will not happen again if the thyroid levels are kept under normal. So it's an uncommon case, uncommon scenario of presentation of thyrotoxicosis. That's a hypokalemic paralysis due to thyrotoxicosis. I think the last case for today, and then we wrap up. This is a 56-year-old male patient. He's diabetic for the last 6 years and is on regular treatment. He's otherwise quite asymptomatic. He monitors his fasting and PP regularly, and they are often pretty normal. Okay, not very bad, not very good. They're fairly reasonably controlled. The recent fasting that we have as a documentation was 116 and 159. He was seen, however, recently because he went to his ophthalmologist, and the ophthalmologist pointed out to him that your retinopathy has been worsening. And the eye doctor told him that you need to look at your blood sugar control. He said, no, my blood sugars are good. There's no problem at all. I've been testing him. He showed him these reports. So he said, what about your blood pressure? He said, my blood pressure is normal. Are you a smoker? Do you have kidney disease? No, he said they didn't have it. So he has never been doing his A1Cs at all, really. He has been just doing a fasting PP. And he did a recent HbA1c, which was 9.2. Not a very, very good lab, I must say, but decent. So I could take it, it must be high. It is not, it may not be 9.2, but it is high. What do you make out of this situation? This is his fasting PP, and we have many such reports in the past which are roughly similar, little plus minus, but not very high, not much higher than this. And his A1C is 9.2. So I think you think it's falsely positive. I think Vaishali actually elaborated all the causes of where you could go wrong. We looked at them. Okay, I mean that is the primary thing, to look first at your lab parameters to make sure that it is a very well calibrated HbA1c. That's number one, of course. Then look at all the other red herrings which can cause either an abnormally high or an abnormally low HbA1c, and one of the primary things if he has been a diabetic for 6 years is to look whether he's got uremia, because uremia can cause abnormally high HbA1cs. But something interesting which I brought to show you, this is just one of the many, that this A1C is actually not fallacious. What you see here is, this is a CGMS, okay, and the CGMS is a continuous glucose monitoring system, much like a BP Holter or a ECG Holter, and it continuously records blood sugars at every 3-minute intervals for the time period that you fit to your sensor. And if you see here, these are the fasting levels, these are the postprandial levels, and you will see that they are always falling in the normal range, which is the green patch. It's only at the post-breakfast time and sometimes at the post-dinner time that the sugars are going high. And they are consistently going high to about 240, 250, it may not be very clear here, but 240, 250 post-breakfast and post-dinner, and most of our people actually do a fasting and post-lunch, I mean by convention. And every time you did that, you were finding it as normal, and it was normal. It's not fallacious, it was normal. But the post-breakfast was going up to 250, and the post-dinner also was climbing up to 200. And there are many such CGMs which I can show you, showing that only post-dinners are going up to 300, and throughout the day, whenever you check it, it's normal, therefore reflecting in an abnormal HbA1c. So the HbA1c doesn't lie often, and if we get a high HbA1c, it is the duty to find out where we are going wrong. So nobody, as I've been harping again and again, the clinician cannot just get up and say this is a wrong report. He has to know then what to do and what to find out. So next time you find such a situation, you could tell your doctor, go back and look at other point parameters during the day to see whether the sugars are normal. And if you address this issue of the high post breakfast and high post dinner with whatever you need to do, the A1C will come down. So this is just another of those catch-22s. Thank you very much, sir, and I have enjoyed this as much as probably you do. Thank you.